What if the blood pressure number your doctor has been telling you to aim for is not actually the best number for you? What if millions of older adults have been given targets that were either too aggressive or not aggressive enough, and that this confusion has led to real consequences? Falls, fainting, kidney damage, heart attacks, and strokes that could have been prevented. I'm Dr. Markus Dexter, and today I'm walking you through everything you need to know about blood pressure as you age, what the latest research actually says, why the old guidelines changed, and most importantly, what your blood pressure target should really be based on your unique situation. By the end of this video, you will have a level of understanding about your own blood pressure that most people never receive in a standard clinical appointment. If you are over 60 or if you have a parent or loved one who is, this conversation matters. Let's get into it. Before we begin, has your doctor ever explained why they chose your specific blood pressure target? Not just told you the number, but actually explained the reasoning behind it? Type yes or no in the comments right now. I read every single one, and your answers shape exactly what I cover next. Let's start with the foundation, because context matters here. Blood pressure is the force your blood exerts against the walls of your arteries as your heart pumps it through your body. Two numbers, the top number, systolic pressure, measures the pressure when your heart is actively beating and pushing blood out. The bottom number, diastolic pressure, measures the pressure when your heart is resting between beats. For a long time, the gold standard was 120/80. For younger, healthy adults, that number still holds up reasonably well. But here is where things get complicated for older adults. As you age, your arteries naturally become stiffer. They lose elasticity. The walls of your blood vessels thicken. Because of these changes, blood pressure tends to rise with age. This is not necessarily a sign that something is catastrophically wrong. It is a normal part of aging. But the question that matters is, how much of an increase is acceptable? How much is too much? And what number should you be targeting if you are 65, 75, or 85? That answer has changed significantly over the years, and understanding why it changed is essential to understanding what it means for you right now. For decades, the medical community operated under a simple framework. Blood pressure above 140/90 meant hypertension and required treatment. For older adults, many doctors were even more lenient. A 70-year-old with systolic pressure of 150 or 160 was often considered acceptable. The thinking was, older arteries are stiffer, they need higher pressure to push blood to vital organs, especially the brain and kidneys. There was logic to that on the surface. But the research began to tell a different story. Older adults with systolic pressures in the 140s and 150s were experiencing significantly more strokes, more heart attacks, more heart failure, and more cognitive decline than those with lower numbers. The lenient approach was costing lives. The turning point came in 2015 with a landmark study called the SPRINT trial, the Systolic Blood Pressure Intervention Trial. Over 9,000 participants, many over the age of 75. Two groups were compared, one treated to the standard target of less than 140 systolic, the other treated to a more aggressive target of less than 120 systolic. The results were striking. The group treated to the lower target had a 25% lower risk of major cardiovascular events, heart attacks, strokes, and heart failure, and a 27% lower risk of death from any cause. That benefit was seen across all age groups, including adults over 75. As a result, the American College of Cardiology and the American Heart Association updated their guidelines in 2017. Normal blood pressure remains less than 120/80. Stage 1 hypertension is now defined as systolic between 130 and 139. Stage 2 is 140 or higher, and the treatment target for most adults, including many older adults, became less than 130/80, a significant shift from the old 140/90 standard. But here is where most videos on this topic stop, and where the most important information begins. The SPRINT trial was groundbreaking. But it had important limitations that you deserve to understand, because they directly affect how its results apply to you. First, blood pressure in the SPRINT trial was measured differently from how it is typically measured in your doctor's office. Participants sat quietly alone for 5 minutes, then an automated machine took 3 readings with no healthcare provider present. In contrast, when you go to a clinic, you may be rushed, slightly anxious, or have just walked in from outside. A nurse or doctor is standing right there. These factors can artificially inflate your reading by 5 to 15 points or more. This is called white coat hypertension, and it is extremely common in older adults. So when SPRINT set a target of less than 120, That 120 was measured under ideal, controlled conditions. That same person measured in a typical doctor's office might read 130 or 135. This means that the sprint target of 120 may actually correspond to roughly 130 to 135 in standard clinical practice. Aggressively medicating someone to reach 120 on an office reading could mean their actual blood pressure is dangerously low. Second, the sprint trial excluded people with diabetes, people who had experienced a prior stroke, and people who were frail or living in care facilities. Its results do not automatically apply to everyone. If you have diabetes, your targets may need to be different. If you have had a stroke, the approach changes. If you are frail or managing multiple chronic conditions, aggressive blood pressure lowering can cause more harm than benefit. This brings me to the single most important point in this entire video, and I need you to hear it clearly. There is no single correct blood pressure number for all older adults. The right number for you depends on your overall health, your medical history, your functional status, and how well you tolerate medications without significant side effects. If this is already giving you a clearer picture than you have had before, hit the like button now and subscribe. I release evidence-based health content for people over 60 every single week. What comes next is the part most doctors do not have time to explain in a standard appointment. Stay with me. When we lower blood pressure with medications, there are always potential side effects. The most significant for older adults is dizziness, particularly when standing up quickly. This is called orthostatic hypotension, and it is especially dangerous in seniors because it leads to falls. Falls in older adults are not minor events. A fall at 70 or 80 can mean a hip fracture, a head injury, hospitalization, and loss of independence. Falls are one of the leading causes of serious injury and death in adults over 65. If we are aggressively lowering your blood pressure to hit an arbitrary target, and in doing so we are causing you to become dizzy and fall, we are not helping you. We may be reducing your theoretical risk of a heart attack on paper while simultaneously increasing your real-world risk of a catastrophic injury. That is not good medicine. There is also a diastolic blood pressure issue that is rarely discussed, and it is particularly relevant to older adults. As you age, something interesting happens to your blood pressure pattern. Systolic pressure tends to rise, but diastolic pressure can actually fall. This widens what is called the pulse pressure, the gap between your two numbers. A wide pulse pressure is itself a cardiovascular risk factor. But here is the problem. When we treat high systolic pressure with medication, we inevitably also push diastolic pressure lower. If it drops below approximately 60, blood flow to the coronary arteries can be compromised. The coronary arteries receive most of their blood supply during diastole, the resting phase between heartbeats. Diastolic pressure that is too low can increase the risk of a heart attack even as we are reducing stroke risk. For example, if your blood pressure is 150 over 65 and we medicate your systolic down to 130, your diastolic might drop to 50 or lower. That is a real risk, and one that requires careful monitoring, not just aggressive targeting. This is the complexity of blood pressure management in older adults. It requires nuance and individualized decision-making, not simply picking a number and medicating until you hit it. Now let me be equally clear about the other end of the spectrum, because undertreating high blood pressure is just as dangerous. High blood pressure is called the silent killer for a reason. Most people with hypertension feel completely fine, no symptoms, no pain. They go about their daily lives unaware that inside their body, excessive pressure is quietly damaging their blood vessels, their heart, their kidneys, their eyes, and their brain. Over years and decades, that damage accumulates. Artery walls thicken, plaque builds up more easily. The heart enlarges from working harder against increased resistance and eventually begins to weaken. The kidneys lose filtering ability. Small blood vessels in the brain become weakened and prone to rupture, a hemorrhagic stroke, or narrowed and blocked, an ischemic stroke. All of this can happen without you feeling a thing. Until one day, something catastrophic occurs. Deciding not to treat high blood pressure because you feel fine or because you want to avoid medication is a gamble with very serious long-term consequences. The evidence on this is not ambiguous. Untreated hypertension shortens lives and reduces quality of life. That is the reality, and it is equally important to understand as the risks of overtreatment. So what is the practical recommendation? For most adults over 65 who are otherwise reasonably healthy, a systolic blood pressure of less than 130, measured properly, is a well-supported and reasonable target. I want to emphasize those two words, measured properly. That means sitting quietly for at least 5 minutes before the reading is taken, arms supported at heart level, appropriately sized cuff, no talking during the measurement, no caffeine or exercise in the prior 30 minutes, no full bladder. These details all matter, and they can shift a reading by 10 points or more if ignored. For adults over 80, for those who are frail, for those with a history of falls, for those who experience dizziness or lightheadedness on current medications, or for those managing multiple serious conditions, a target of 130 to 140 systolic may be more appropriate. The risk of overtreatment in these individuals can outweigh the benefit of aggressive lowering. And as I mentioned earlier, diastolic pressure should generally not be driven below 60, particularly in anyone with known coronary artery disease. The key principle is this: your blood pressure target should be individualized based on the full picture of your health, not based on a single guideline number applied uniformly to every person of a certain age. Has your doctor ever discussed your diastolic number with you separately, or explained the risk of it going too low? Drop your answer in the comments. These are the conversations I want to help you have more of. Medication is only one piece of blood pressure management. Lifestyle changes can be just as effective, and in some cases, more so. Here are the 6 most evidence-supported interventions. 1. Reduce sodium intake. As you age, your kidneys become less efficient at excreting sodium, meaning dietary salt has a bigger impact on your blood pressure than it did at 40. The target for most older adults with hypertension is less than 1,500 milligrams of sodium per day. The hidden sources are the ones that catch people off guard: canned soups, deli meats, bread, cheese, restaurant meals. Start reading labels. Cook at home more. Use herbs and spices instead of salt. 2. Regular physical activity. Consistent moderate exercise, walking, swimming, cycling, light resistance training, can lower systolic blood pressure by 5 to 8 points. That is equivalent to some medications. Aim for 150 minutes of moderate activity per week. If 30 minutes at once is too much, 3 10-minute sessions throughout the day produce the same benefit. 3. Maintain a healthy weight. Even a modest 5 to 10% reduction in body weight can produce meaningful blood pressure improvements. You do not need dramatic weight loss. Movement in the right direction matters. 4. Manage stress consistently. Chronic stress keeps your body in a sustained state of elevated cortisol and adrenaline, both of which raise blood pressure over time. Whatever genuinely helps you decompress, meditation, time in nature, reading, gardening, make it a daily habit, not an occasional one. 5. Prioritize sleep quality. Poor sleep, and particularly undiagnosed sleep apnea, can raise blood pressure significantly. If you snore loudly, wake up unrefreshed, or feel excessively sleepy during the day, talk to your doctor about a sleep study. Treating sleep apnea alone can lower blood pressure by 10 points or more in some patients. 6. Moderate alcohol consumption. Excessive alcohol is a well-established driver of hypertension. Keep it moderate if you drink. And the most recent research suggests that the supposed cardiovascular benefits of light drinking have been significantly overstated. Now, home blood pressure monitoring. I am a strong advocate for this, and here is why. A single reading in your doctor's office gives you 1 data point out of a 24-hour day. Your blood pressure fluctuates constantly in response to stress, meals, activity, medications, and sleep. Home monitoring gives you the full picture. Use a validated automatic upper arm cuff, not a wrist monitor. Measure at the same times each day, ideally in the morning before medications and in the evening. Take 2 to 3 readings each session, about 1 minute apart, and record all of them. Bring your log to every appointment. This data is more valuable to your doctor than any single office reading, and it protects you from medication adjustments based on inaccurate white coat readings. Let me bring this together clearly. For most older adults who are generally healthy, a systolic blood pressure of less than 130, measured properly, is a reasonable and well-supported target. For those who are over 80, frail, prone to falls, or managing multiple serious conditions, a target of 130 to 140 may be more appropriate to avoid the risks of overtreatment. Diastolic pressure should not be driven below 60, particularly in anyone with coronary artery disease. Measure blood pressure correctly and consistently. Add home monitoring to your routine. Build lifestyle management, sodium reduction, regular movement, weight, stress, sleep, and alcohol as the foundation. Add medication as needed to reach your personalized target. And most importantly, use this information to have a better, more informed conversation with your own doctor. Ask why a particular target was chosen for you. Ask what happens if you wait and try lifestyle changes first. Ask whether your diastolic number is being monitored carefully. Make sure the benefits of your current treatment plan clearly outweigh the risks. That is what individualized medicine looks like, and you deserve that level of care. If this video gave you clarity, share it with someone who is navigating blood pressure decisions right now. Subscribe for more honest, evidence-based health conversations every week. I'm Dr. Markus Dexter. Take care of yourselves and take care of each other. I will see you in the next one.